You're listening to the Autism Weekly podcast. Each week, we share community voices and bring light to stories that increase awareness, acceptance, equity, access, and inclusion. If you haven't already, subscribe to join the Autism Weekly family. I'm your host, Jeff Skibitsky. This week, we welcome Dr. Joseph Buxbaum, a leading neuroscientist, autism expert, and director of the Siever Autism Center. With his vast expertise in genetics, neuroscience, and clinical applications, Dr. Buxbaum will shed light on the latest advances in autism research and share practical advice to help families make informed decisions about their child's care. Welcome to the podcast, Dr. Joseph Buxbaum.
Well, thank you so much for having me, and I'm looking forward to digging deeply into the questions you want to raise. And I'm looking forward to not only speaking to you, but also hearing from families if they want to hear more.
Absolutely. And before we get started, we're in a field where passion drives a lot of the decision making. Passion is probably driving the research questions. What brought you into the field of autism? Is it the understanding piece? Is there a personal connection? Or is it a matter of, you want to be out there to be able to provide more opportunities for people in the future so that there isn't this barrier in care or barrier in knowledge?
Yeah. So I came to Mount Sinai in 1997 with the thought of working in the Department of Psychiatry and bringing my skills in genetics and molecular neuroscience to some of the psychiatric illnesses. I was actually already working on Alzheimer's disease, and there was the Siever Center that I'm now the director of already existed when I arrived there, and was looking for somebody who could bring in genetics into autism. And the reason for that was over the past almost, let's say, 10 or so years, it became increasingly evident before I arrived that autism had a very, very significant genetic component to it. And when you know there's a genetic component, you want to figure out what are the specific genetic risk factors. And so at the time, I was attracted to it because I thought we could make some progress, which we certainly have. And also, I'm a dad, and I know people with on the spectrum, and I know people that have a child, for example, with profound autism, maybe nonverbal, or maybe with intellectual disability. And I know how challenging that can be. And I thought, if I can make a difference, that would be important. Interestingly, I didn't have a personal connection in terms of a family member at that time, but now I do, because autism is, it's not a rare thing, and I have a grandchild now that has autism.
And I mean, it's those sort of connections. It's the idea that I came in, I'm studying, the neuroscience, I'm studying Alzheimer's, and I'm seeing some of these other components that are directly related. And how do I work through understanding some of those neurodevelopmental disorders? And that's intriguing to me. But it also points out is that when you started in the field, things were starting in a very different place, and it's evolved over time. I think that there's potential that there's some confusion that has crept back into the field right now. And whether that is for autism or just not understanding what autism actually is and what we should be looking at to be able to create more opportunity for people to live their best lives. Where has this evolving component of autism and understanding and research gone, and where are we right now that maybe we should be putting a little bit more attention into?
Well, there's so much going on, especially now. But one of the things that I think has really skewed people's understanding of autism is the decision, which was made on good clinical and even research grounds, to create a spectrum diagnosis of autism spectrum disorder, which is the clinical term, right? Which most people just call autism, meaning something more broad. And historically, as I think you know, and certainly your audience knows, we had autistic disorder, which we considered more profound. We had Asperger's, which we considered, with some challenges navigating some aspects of social relationships, but generally doing well. And then we had something in the middle we called PDD, right? So pervasive developmental disorder. That was not, something in between autistic disorder and Asperger's. And that was very useful because people understood that, there was quite a significant range across the autism diagnosis. There was a decision made so DSM-5 to call it all one thing, autism spectrum disorder. And the motivator for that was that, somebody could come to one expert center and get a diagnosis of PDD and go somewhere else and get a diagnosis of Asperger's. So they wanted to have, because the lines could be very fine, right?
Mm-hmm.
And they wanted to make it more easy to have a consistent diagnosis, right? But what they added, which most people don't forget to discuss, is levels of support required, right? But from a level of 1, which is minimal support or no support, to some moderate level of support, to very significant ongoing support. And a new term was put out just a couple of years ago by the Lancet Commission, a Blue Ribbon Commission, that was trying to deal with the fallout of this kind of conflation in the public mind that it's all one thing, to realize that, it's a spectrum, certainly, but what's now being called profound autism are those individuals who will need access, 24-hour access to adult care, right? So, and they may be able to do some things independently, but they'll, on any given day, they may need specific support just to get through the day, to navigate the world. Very often they'll have intellectual disability, or they'll have limited language, or both, right? And so I really am endorsing the term profound autism, because everything we think about, if you and I talk about therapies, they're going to be very different for somebody who is, possibly nonverbal, has intellectual disability, has difficulty navigating the world, compared to somebody who needs a little bit of help in preparing for a job interview, which we do. That's an important part of, we have a program called Jobs, which is, how to navigate the back and forth in a job interview for somebody on the spectrum, right? So those are quite different needs. And I think one of the problems that, the clinical and research community created was to develop this terminology that makes people kind of, in their minds, put it all together as a single thing, which it's not. And unfortunately, there's also a lot of misinformation out there, right? I mean, again, as you know very well, and I'm sure your audience knows as well, there are all sorts of, snake oil treatments, right? You can go to Mexico and you can get stem cells. You can get stem cells in America now. You can, you can do hyperbaric. There are many, many things, and there's also diet-related things that, some of them won't do any harm, but some of them can actually do harm, and yet they're being promoted as potential treatments. And that's been a very big disservice to families, because, passion is a great word. The families are passionate about their child, or about themselves if they're the ones with an autism diagnosis, and they want to live their best lives, or they want their child or their family member or their friend to live their best lives. And so, of course, they're going to look for interventions or therapies if they think they're needed, and they deserve to get the facts, right? They deserve to have the same level of rigor for so many of the treatments. Like if I'm giving you a medicine, an FDA-approved medicine, there's a very specific process of how that gets to be approved and how it can be given to you and what kind of surveillance and all that sort of stuff. If I say this supplement or this dietary change or this, this chamber is going to help you, I don't have the same kind of controls or regulatory responsibilities that I do if I gave you a pill. But some of those supplements and some of those other treatments we know have actually, injured kids and injured adults, and even very recently, and people lost their lives with some of these treatments, right?
Yeah.
So it's concerning that so much of what we can do that is being done is not tightly regulated.
Absolutely. And I mean, when you're looking at such and I'll say vulnerable only based on the idea that these are folks that are looking for answers. So they're searching anywhere they
Exactly.
can get to be able
Exactly.
to be given information.
Yep.
And if what they're seeing is something that could be harmful, that's scary. I think it's also scary, and you hit on this, is the generalizing of
Yes.
autism. And whether you're researching, the appropriate treatment or the phenotypes or anything that might be going on for somebody with profound autism versus a somebody who potentially is a leader of an industry who might be level one autistic,
Right.
and that middle ground where maybe it's, I'm tailoring some social components and I'm looking at, being able to make sure that we're preparing somebody so that mental health issues don't creep in, is that I would
Right.
imagine treatment and research need to align better on those pieces. What are we doing right now? And maybe we can start with profound autism. What are we doing right now to be able to differentiate in research world, to be able to look at what is different for somebody with profound autism, whether it's on the treatment, whether it's on the understanding of, how their neurological system is working differently, or anything to those regards.
Yeah, so even that we don't have a consensus on, right? Historically, for example, neuroscientists would do an MRI, a functional, MRI on the brain of somebody with that they wanted to study who agreed, and maybe they'd give that person a task to do in the scanner. So they're in the scanner, they're doing some they're navigating a game, for example. And then you can actually measure how the brain is responding to various stimuli in that process, right? And the decision making, for example, you decide to turn right or to turn left in this, virtual reality as an example. And so we can learn about how the typically developing brain works and how the neurodiverse brain works in that system. But I can tell you that somebody with profound autism is probably not going to be included in that study because it takes, uh, you know, a certain level of comprehension of the task, of being able to navigate it. Often there are motor abnormalities, maybe they have limitations in fine motor skills. And so some of the neuroscience of autism historically focused on individuals level one, for example, just to use that term. And so the first thing that had to happen was we had to begin to embrace, you know, level three, if you will, or profound autism. We had to figure out how to work with those individuals, which could be very different than what you're working with somebody who is, let's call it Asperger's, right? And so, for example, as you know, autism, very commonly there are sensory reactivity differences, right? So they're very sensitive to auditory, visual, or tactile stimulus, for example, or they might be seeking, right? Or they might be non-responsive. And we have questionnaires which we can ask an individual or their caregiver, but they're imperfect. And of course, if somebody's nonverbal or even pre-verbal, you can't ask the same questions, right? And so, you know, uh, two people at the Seaver Center developed a toolkit of toys where they can train an expert rater to present these toys. And some of them have flashing lights, and some of them are prickly, some of them are soft, and actually gauge and measure the reaction of the individual to the three domains of visual, auditory, and tactile, and see whether they are hypersensitive, hyposensitive, or seeking. And that turns out to be, the first time we can actually get insight, like direct insight into what somebody's feeling about sensory reactivity who is nonverbal or preverbal. And so now many people are beginning to see that these we knew it, but we're seeing it now in profound autism, that the level of sensory reactivity does correlate with symptom severity, right?
Mm,
And so the question then becomes, if you could reduce some of that sensitivity or balance it the way it should be, maybe some of the other symptoms will go away. Now, we don't know that, but you couldn't even get an entree into that until you were able to develop some measure that said, okay, this individual right now, the tool called the SAND is was developed and validated in children, and now we're trying it in older individuals as well. But I'll talk about children because that's where it's been validated. You know, if you discover that that child is completely hyposensitive to tactile stimuli, that's important. These are the kids that could actually injure themselves and not tell you about it, right?
Hmm.
They can be that hyposensitive that they can have a significant, they can crash into something and get hurt, but they won't sense it the same way you and I would. And that's kind of
Yeah.
important. That's important to know. Or if you see that they're, incredibly seeking, right? They just something visual. They just, they hold it over their head because light goes through it, and they might stand there for 45 minutes, right? That obviously it's what they want to do, but it may also be that if that could be tempered a little bit, it might be easier for them to attend to other things in their environment, right?
Yeah.
So that's a long-winded answer to your question, but I might not have
No,
answered everything.
I think that's a wonderful example, though. It outlines that understanding some of these research questions and getting some of this information back can really help to start prioritizing where
Absolutely.
treatment needs to be done. So if I have somebody where their sensory needs are so heightened, as a treatment provider, that should be exactly where I should be prioritizing first, being able to help stabilize, to be able to give somebody the chance to use their skills as I'm starting to teach it. And I think that these are so important, every component that we're trying to research, and the more directed we could get to understanding different groups that are identified as or identify autistic, and that we can narrow it down, the better we're going to be at being able to create paths to successful jobs, successful friendships, successful relationships. I mean, the whole world that we're trying to open up for everyone. One of the things that kind of hits me a little bit, and you're talking about a lot of the research that has come about, that takes volunteers. And oftentimes these volunteers are not going to get the direct effect. Sometimes they're giving back. They're giving forward, I guess, to the next group of, I can help somebody understand me better. I can help somebody to be able to empower me more. The next version of me that's coming down in 40 years or 50 years, whoever that child might be. And right now, I feel like in a way, people are backing off over the last month or so, 2 months, to say, I want to participate because they've felt somewhat attacked as far as saying, well, you've devalued me a little bit. You've devalued who I am. And I don't want to put myself out there knowing that the response is different. How is the research community responding to that to be able to help people understand giving back or being able to give your time is still going to be valuable going forward, and we're going to make use of all these decisions? Are there research projects at the Seaver Center that you're working on right now that are going to be helpful for that next generation of autistics?
Yes, I mean we are first and foremost a research center. So the full name is Seaver Autism Center for Research and Treatment. We have a treatment arm, but we also know that the treatments to date, many of them don't really address some of the core features of autism, and certainly some of the things we mentioned in terms of intellectual disability or lack of language, we have no treatments for those, right? And so we do think that we can do much better going forward in terms of developing treatments that can actually be transformative for individuals all across the spectrum of autism. And we put a lot of effort in that. And it is just like you said, I mean, it's entirely dependent on the goodwill, the passion, and the compassion of individuals with autism and their family members who, as you said, realize that this research may not directly benefit them. It may, but it may not. And but it will help others, you know, in the bigger picture over the shorter term and certainly over the longer term as well. And I think everybody who does patient-based research or clinical research is, you know, incredibly grateful to the families who give of their time. And some of them, these families are just as busy as you and I, and even more so if they're dealing with, challenges in the family. Um, and they're still, we don't ask them to just come in for 5 minutes. Often we ask them to come in for several days in a row or come in multiple times. And, and they're willing to do it because they they understand how important it is for the autism community, right? And that is really, it's really quite interesting. And this is a bit of a diversion, but you know, in bioethics, people talk about the various benefits, benefit to self, benefit to family, benefit. What we don't talk about, we tend to de-emphasize in bioethics the benefit to our community as being a major driver. But these families are being driven by that. They really aren't, most of them, they all hope that it'll make a difference for their individual family member or for themselves. But they're also saying, and if not, not. I still want to do this. And there's a lot of, a lot of compassion for others in that stance. And of course, right now, there's been, some statements that would be, wouldn't call them the most compassionate or thoughtful. And even some of the proposed studies, we get a lot of concerns. We've heard a lot of concerns from individuals on the spectrum or their family and their families that, you know, this so-called autism registry or autism database, what is it? And, how is it going to be used, right? When you're meeting with a clinician or a clinician researcher, um, you're looking for, like you said, respect, mutual respect, right? You're looking for, privacy and consent. You want to agree if you're being a part of a research study. You don't want your data going elsewhere outside of a constrained thing. And you're looking for, quite honestly, a compassionate person to work with, right? And we have the situation where we're talking about a national database where the consent is probably not going to be there, right? Um, I think people have legitimate concerns about privacy because we've already seen some of the access to national data has been going as, the privacy thing has not been well protected, or it's not the way we expected it to go historically. That respect dimension seems to be a little bit, lacking. And then we have the added fact that we have some of the people in leadership talking about, you know, that empathy, the toxic empathy perspective, right? Elon Musk has said it on a Joe Rogan show that, empathy is bad for Western civilization, right? And you don't want to hear that from your clinician, and you don't want to hear that from the researchers who are, you know, you know, begging you of time and energy to try and help you. If they're really not, if there's no empathy there, you shouldn't be showing up, right?
Hmm.
And so there's a lot of concern about that. And even from the point of view of a researcher, right? Even if you're just, you just say, okay, there'll be a database and I want to be able to access it too. You probably won't be able to because, as you know, right now, the data that's being taken into Doge is still restricted to only government officials with a certain access. So if Doge, if Doge did some autism work and they told us the results, I could not access that data because I'm not a government official. So one of the key things in all science is that the data is available for anybody to examine themselves and see if they agree with your conclusions. Big data, which is what we're talking about here, big data comes with a huge burden of quality control. We generally, we work on genomic data or national registries from Scandinavian countries or Medicaid, Medicare registries in the United States. We probably spend 80% of our time with data cleaning,
Hmm.
right? Because you have millions of records. You don't go through them one by one. You develop algorithms and you test them and retest them, and then you find an error that's something you missed, and it caused you to get a spurious result, and then you have to go back and correct your data cleaning step. If you don't clean your data well, it's very easy with very, very large data sets to get false findings, right? And so the expectation in science is that if you, Jeff, do a large study, that I can access that data and analyze it my way. Do I come up with
Yeah.
something different or the same? And maybe I come
Hmm.
up with something different, but they're both correct because I looked at a different perspective. or I come up with something different because I made an error, a tiny, tiny error in the 1,000 lines of code, or you made the error, right? And I rely on you and you rely on me. It's always embarrassing to be caught out, with the problem in your data set or your analysis. But I'd much rather be caught out than become just, an immutable truth because nobody else can look at it, right? So I think those concerns we're hearing from families and from individuals are understandable, right? That
Absolutely.
it, there's not been a lot of clarity, and so people are looking at other examples in parallel going on, which is probably, I would say, Doge, some of the Doge data access, and they're listening to what people are saying about, and whether they're showing proper respect and compassion and care. Right? And I think the
Yeah.
care, and I have to say, I think the care is there in the government, certainly in HHS and in NIH and CDC and everywhere else. But I think, you know, the mechanism hasn't been thought through together with people on the spectrum and their family members in a way that would be respectful and thoughtful.
No, absolutely. And I think that that empathy piece is so important because we're all, this is working with people. This is working with people's lives. This is working with people's emotions. Yeah, if you don't enter into that with some perspective, some empathy, and even sympathizing with the way that the society might have been responding to them, is that you're not going to get to the heart of the right questions. But you spoke about these large data sets, and when you block that off from researchers whose job is to be inquisitive, to come up with questions maybe we haven't thought about, and put together the research to be able to kind of look at the answers that become of it, you if you block that off, I think that you're limiting the understanding that we could have. And one of those pieces I'd love to talk with you about just briefly is that you mentioned genomic research and understanding genes and their effect with autism. I think is something that has come about over the years and is very valuable right now. We've made a lot of strides in that area, and it could influence the way that we're looking at med management. It could influence the way we're looking at treatment paradigms. But how do you see the effect of genes right now and genetics right now in general and its role in research in autism?
Yeah, so I think that's really one of the biggest successes, and certainly in psychiatry, is all the discoveries that have been made around the genetics of autism. And so the first discovery is, even Leo Kanner, when he described what we now think of as, profound autism, artistic disorder, he realized it was innate, right? He was talking about how these kids, these 6-month-old kids, were not making that anticipatory gesture of reaching up when mom or dad reaches down to pick them up, either in response to mom or dad reaching down or to try and get mom or dad or anybody in the family to pick them up, where they put their hands in the air. And he noted that the kids he was studying and called, autistic disorder of affective contact didn't show that at 6 months of age. So he realized that the autistic part, the inward looking part that he saw as they aged, already was there at 6 months of age. And he called it, the paper was about an innate disorder, right? Innate. So he recognized, and that was important. There's people were talking about maybe it's bad parenting, maybe it's some psychiatric decompensation. But he said, no, it doesn't happen when it doesn't start when I'm looking at them interacting with me. It started before that, right? And then, a few years later, the work of Susan Folstein and Sir Michael Rudder, who was knighted for his work on child psychiatry, showed that like the more closely related you are, the more likely you are to share the trait of autism. And that's been done first in small families, but my group and other groups have done it across entire countries and even 5 countries at a time, right? So, you don't even need to know that 2 people are related. You can use genetic markers to say they're related by a tiny bit. And then how likely are they to share any trait, right? And if it's height, they're going to the degree of sharing of height is going to go pretty linearly with the degree of relatedness. And autism turns out to be the same thing. And so we began to realize, and that's about the time I started at the Sieber Center, that autism has a very high genetic load. And the next question, which has been the challenge, is figuring out what are the specific genetic factors that contribute. And they too cover a spectrum, different kind. There are what we call common variants, so things that you and I and everybody has some of, but if you had way too many, it could affect some of your ability to navigate certain things, right? We call those, so those are, they're common variants. Everybody has a few and some people have a lot. And maybe that causes a personality style, maybe it causes a trait, maybe it causes whatever. But each one of those variants by itself does very little. It's the combination of many hundreds. But we've also found that a non-trivial part of autism, and particularly autistic disorder and profound autism, is caused by mutations. And the mutations weren't even there. They're spontaneous mutations. So they weren't found in mom or dad, right? So if you think about, Down syndrome, there is a high rate, relatively high rate of autism and Down syndrome, right? So Down syndrome is an example of a new spontaneous mutation, right? Mom or dad typically won't have Down syndrome, but in the formation of the sperm or egg, there can be a mutation, and then the child takes that. We call that de novo, meaning a new mutation. And when the new technology for gene discovery came out, first at the Human Genome Project, and then became after that more and more available, and then the NIH was visionary. You remember the ARA funding from 2009 when American Recovery and Reinvestment Act that Obama and Biden signed. And so a small amount of that money went to the NIH, and the NIH decided to use it for things that they just were like, very high risk, but possibly very high reward. And they gave a few groups, including our consortium, some money to use this new technology of sequencing every base, every coding base, every gene in a person's genome to see what we could see. And we did just 200 families. And even there, we began to see these new mutations in some of the kids. And we said, wow, with just 200 families, we see this. What if we had 2,000 or 20,000 families? So as of today, we have studies in tens of thousands of families, all of whom who are happily contributing their time, energy, and blood or saliva samples to find these genes. And like I said, much of what we're finding are these new mutations that actually account for most of the risk in that individual. Okay. And again, it's much more likely to be found in profound autism than, let's call it Asperger, but it's found in everybody. I mean, all of us have a few of these new mutations, just by being human. Some of them have no impact. Some of them have significant impact. Some of them will affect your development in very significant ways, right? And so that space of genomics discovery in autism is now leading the charge in terms of new treatments. So if you just take, I think many people have heard of Fragile X syndrome, right? Mm-hmm. Which is, again, a rare genetic event that can cause autism too. And some of the biochemistry of Fragile X has been so well worked out. There's an ongoing clinical trial with a drug called a phosphodiesterase inhibitor. And in the first studies coming out of that, there's evidence for cognitive changes, cognitive improvements in Fragile X syndrome. So this is part of, when we think about autism, we talk about the social dimension. We talk about profound autism. We're also talking about the added burden of intellectual disability, cognitive challenges, language challenges, and so on. And in the Fragile X trial, that's been published, they actually saw improvements in cognition and language. Angelman syndrome is another syndrome that's caused by a genetic mutation, and it's not so rare in autism. Maybe 1% of individuals with autism will have mutations in that region. And there too, there's 3 companies are developing treatments to actually target the Angelman gene and to turn it back on. It gets turned off. And they're seeing again that these individuals, both adults and children, are showing improvements in things like cognition as well, which is sort of the holy grail, right? I mean, we can do pretty well if somebody, as you know, somebody comes in and has some social challenges, like as we talked about, needs help navigating job interviews, or needs help just developing some framework to keep in touch with friends in a more spontaneous way, or maybe not spontaneous, but a more regular way, if you will, to help them. We can train people to do that very easily, right? I don't want to minimize the challenges with somebody, even with level 1 or Asperger's. They're coming to you and they're coming to me because they have challenges. They want to live their best lives, right? But the behavioral interventions that either of the ABA types or even just social skills training or jobs training, those actually can help somebody quite a bit, right? But if you layer that onto that, the challenges of intellectual stability, difficulties navigating the world, adaptive skill, and language, it's very, very hard to help.
Absolutely.
And so if we can make a change for some of those parts of the most severely affected individuals, profound autism, we think that we can, the combination, as you said, medical management that might deal with some of these very challenging, neurological, medical, however you want to put it, conditions, and then the behavioral treatments on top of that, we can expect, we can expect a lot of progress.
Absolutely.
And these first trials, they're so important also because I have to say it out loud. Pharma is very cautious. Pharma is very risk averse. And the reality is that profound autism and any kind of intellectual disability syndrome, pharma has not touched for decades. Right? There's just as much intellectual disability as there is autism, and we don't even hear about it in the news. It's kind of the forgotten illness, right? Ever since, because pharma just doesn't know if it's tractable. If we show, and pharma is now paying attention with these trials I just mentioned, if we can show improvements in some of these kind of, most basic cognitive and developmental and neurological dimensions, pharma will, push people like me out of the way and say, hey, we don't need you anymore. We do this much better than you. And then we'll see a real change in how we deal with these dimensions of profound autism, which will help everybody, which will help individuals with profound autism, and we'll get better and better, across the spectrum.
Yeah, and when you're talking about all those pieces, is that the one thing that kind of hits me is that it's part of a typical healthcare model. You're looking at all of those components, and research is guiding to that. So whether it's therapeutics, whether it's med management, whether it's just being able to empower and inform a family on how they need to prepare for the rest of, or the next few years. All of these things become so important for any healthcare model.
Exactly.
And you're working really hard right now on being able to kind of maintain that and keeping the right kind of thought process in there. And like you said, if something comes up and there's research and it takes us all out of a job, that's absolutely wonderful. If that research and that byproduct of that research is that we've now empowered everybody to make a choice to be able to change their life in the way they want to.
Yep.
But what other clinical trials should we be aware of? Or what are some of the things that you think are emerging therapies that we need to put more time, energy, research into right now?
Yeah, that's a great question. As you've already said, I'm very steeped in the genetics world, and I think it's really kind of doing amazing things. One of the things, again, that we see a lot in autism across the spectrum is epilepsy. And some of that epilepsy doesn't respond to typical interventions. It's more intractable, right? One of the things that the new foundation called ARIA is going to be focusing on is methods for regulating epilepsy through a method called closed loop deep brain stimulation. So basically train a computational system to neutralize a seizure. And, that's something that, as you know, people across the spectrum can have epilepsy, and it can be quite devastating, right? And to be able to think about how to treat that effectively with some, new, fancy methodology, actually training a computational model to to sense the first waves of epilepsy and neutralize it by changing the currents in the brain. I think that's going to be, again, focusing more, as I said, we tend to focus on profound autism because we do have a lot to do. We do have lots of many tools in our toolbox for people who are, let's call it Asperger's or level 1. But then it peters off very, very quickly, right? And so the epilepsies I'm very excited about. I think one of the issues when you go back to just behavioral interventions is we also, kind of like I said before, we don't, you and I can decide tomorrow that we want to package a training program and just put it out there and say for X dollars we'll teach you how to do this, right? Again, if this was a drug or medication, we couldn't do that. We'd have to show that it actually did something. Behavioral interventions and all these training programs are rarely actually rigorously studied, right? Or alternatively, they're rigorously studied in a very, very pure academic center, and then they're pushed out to the world where all those guidelines are not so well followed. It's not to say that they don't work, but I would love it if we did a better job of saying this works really well, this works less well, or this approach works really well for this individual, this with these kinds of concerns, and not so well for this person, but this other thing works. So I would love there to be more formalism in taking these various, even if it's just jobs training or social skills training, like what really works for whom, and how do you kind of match it up, right? And as across the United States of America, every state has different rules about what behavioral intervention is approved by the state. And in some states, they say only X because it has, scientific evidence. In other states, they say, well, we're not here to judge scientific evidence, so anything goes, right? And, I get it. We understand why they do that. But wouldn't it be nice if there was like a rigorous kind of, established hierarchy, just like you said, as is any other medical condition? This is what first we try this. If that doesn't work, we have a backup, right?
Yep.
And we don't.
It's almost taking the National Standards Project to another level. It's taking, almost saying, okay, well, we set a foundation by doing this National Standards Project a few years back to understand, what are empirically validated therapies, what are emerging therapies. But now let's take this to another level to really look at who is it benefiting, what type of person is going to be able to access different types of treatment best, and use that information to create a real medical necessity model. So it's not arbitrary based off of who your state government is or who your funding source is. This is the appropriate care model. Like, let's just do it right.
Absolutely. And I think you intimated that access is also a big thing, right? People are trying very, very hard to develop tools that, somebody who doesn't live near next to a major medical center can access as well, right? Can we use the internet? Can we use, and those are proving quite challenging, but obviously, they could have the broadest reach. So again, if we could develop tools that really can work through internet, through cell phones and so on, and are effective, wouldn't that be wonderful, right? That it's not a question of, not only who's in charge of your local government, but also what kind of access you have. Where do you live? Are you rural area, urban area? Are you living overseas and doing some work in another country? Are you in the military, right? And suddenly, you're military family, and you may not get to choose where you're going to be. Sometimes, and so I would love to see that emerge. And of course, many people are working on these kinds of things and doing very good jobs. But there really is a difference between the real world and academic medical centers where, we can control everything. And so making something that works first in the academic medical center and then also in the real world is the challenge.
Yeah, well, it's that community academic partnership, and the more that we can do that, the better. But then also it's realizing is that anytime where we're cutting funding from academic universities that are studying some of these subjects or that are putting out and being able to guide practitioners on better models of care over time by generating research, that's also fearful. So, I mean, I think that we all need to have that voice. And I know I'm on a little bit of a soapbox here, but we need to be advocating for people to be able to access this research funding and to be able to inform us more and more so that we can get better as clinicians as time goes on. Where can folks access what you all have been working on, and where do you suggest people get some of these resources on some of the research that's out there, or some of the emerging studies that they should be learning about right now?
Yeah, that's a tough one. I mean, we have an annual conference where we always speak to a mixed audience of non-specialists and specialists. And, it can be quite dense because we're trying to reflect the newest breakthroughs, and some of those are quite cutting edge and hard to understand. But we always try and do things. We always try and have programs to let people know what's going on. We have programs that we present. We make presentations around specific genes we find, new therapeutics, and many groups do that. Many universities, academic medical centers, try and have these educational lecture series that they do their best, and scientists are never the best at talking to a mixed audience, but they do their best to make it comprehensible. And I think that those are I go to them myself because I learn a lot. But to your point, it is very hard to keep up on any kind of fast moving area, right? If you said, where should somebody go to learn about the newest innovations in quantum computing, yeah, if you wanted to follow that, it's going to be hard, right? You have to have some kind of expertise. I think we do better in the autism community because we do all try and communicate with not to lay audiences, but even clinicians and researchers who don't know about where we are with autism. But it's not easy, and I do find that some of these conferences that are properly tuned for a mixed audience are actually quite good. And we've done it now for over 30 years. And, we have a dedicated following of people who like to come, I hope.
Yeah. Well, even having that virtual side to it nowadays, it gives somebody the access where maybe I couldn't get up and go to Florida, New York, wherever it may be, to attend the conference. I can still be a part of it. And having access to professionals as a parent is amazing. It's that having that chance to be able to ask the question, to be able to even get 2 minutes of FaceTime, just to be able to say, hey, this is what my real concern is. Where do you suggest I go? Where do you suggest I learn more? I think that's so valuable.
Yeah.
But and where else? And for your center of research specifically, for the Seaver Center, is that for people to be able to follow some of the research that you all are putting out, is there a website? Is there any information for us to be able to kind of learn more about what you all are thinking?
Yeah, so we most of we publish, the Seaver Center probably publishes about 40 or 50 articles a year, but those are really for, they're very concise. They're for specialists about one step forward, right? We do our very best to to have a web presence, and we do speak a lot, podcasts and things like that. We have our own podcasts, and we have I would say we have a Twitter presence and a Facebook presence. It's I should do much better in that because I don't, but we are we are trying to do outreach quite intensely. We do a lot of work through some of the systems. We have a program in the Museum of Natural History for people to come early and kids on the spectrum. We work with some of the other museums. We have our, as I said, social skills training program and our jobs training program. But in terms of sharing where we are in terms of advances, it tends to be the annual meeting and a little bit also on social media. And we should
we'll definitely give links to all of the social media that you're doing, and then also to the webpage. And Dr. Buxbaum, I really appreciate the time that you spent today to talk about these issues. I think that it's empowering for families to know that we're doing a lot of work out there and that the research community is putting in a lot of effort to better understand, better empower families, and look for ways to be innovative in the way that we can solve problems, or to be able to empower people. And the profound autism families is that they're looking for solutions that are out there. They're looking for more education, more opportunity, more ways to be able to understand their child. And the funding hasn't been directed to really focus on that population in the way that it should be. But I think it goes throughout the spectrum. I think the more we can tailor it, the better. So thank you so much for joining us today.
It's been a real pleasure. And I do want to echo what you said, that it's a worrying time because of all the talk about, cutting resources for research and for clinical patient-based research, especially as well. I think there's no question that the U.S. has been the leader in these kinds of things on every level, in terms of autism understanding, autism therapy, autism behavioral treatments, autism everything. And we only hurt ourselves by limiting our funding in that domain. So I really appreciate being on, talking to you, Jeff, and I appreciate the opportunity. And I look forward to more good news across, every level for people on the spectrum.
Oh, well, thank you.
Thank you for listening to Autism Weekly. We hope you tune back in next week to learn more about autism in the real world. Autism Weekly is now found on all the major listening apps, including Apple Podcasts, Stitcher, Spotify, Amazon Music, and more. Subscribe to be notified when we post a new podcast. Autism Weekly is produced by ABS Kids. ABS Kids is proud to provide diagnostic assessments and ABA therapy to children with developmental delays like autism spectrum disorder. You can learn more about ABS Kids and the Autism Weekly podcast by visiting abskids.com. Thanks for tuning in. See you again next week.